Good evening, everyone. I am so glad that you all can join us for another menopause chat. I am really excited about tonight's chat. As you all know, February is Heart Month, where we like to bring up an awareness of heart disease. And since heart disease is a significant cause of morbidity and mortality in women, I am excited to share what we know about heart health for women, and what you can do at home to be improving your risk factors and preventing this. So I'm joined today by Dr. Adrian Topic, who is a cardiologist at WellSpan who practices in Lebanon. And
I'm happy to be here. It's very exciting.
So it seems that so in general, women compared to men are heart healthy, and we kind of leave men until menopause. There seems to be something that happens during that transition. Right. So what do we know about that?
Sure. Let me start by saying that heart disease is one of the leading causes of death for women, and it's something which is why we have Red Heart Month in February, because we want to raise awareness for that, both for all genders as well as women specifically.
And I think
I'm not going to cut you off. No, it's all good.
But I think, in my practice, I have a lot of patients who worry about breast cancer and other reasons, other diseases. But I don't think heart health is on most of our minds. Right. But it is a leading cause.
It is a leading cause, and it's something to be very aware of and to be cognizant of as we're choosing our lifestyle to be as healthy as possible, because the earlier that we start a healthy lifestyle, the better it is in the long run. We all know this, the better habits that we start early, the better habits that we maintain. But we do see in women that for the most part, younger women, women who are of reproductive age don't have as many heart events as men. They're male counterparts of the same age. Women tend to have about a 10 to 15 year delay of cardiovascular events compared to their male counterparts. And one of the things that we think leads to that difference is menopause and our estrogen levels, our hormonal levels in our body, with women's hormonal levels in the women's bodies. And when we reach menopause in the premenopausal period, a year or so of irregular menses, and then during menopause, and then about the year or so after menopause, sort of as we have irregular events, that time period, that transition, menopausal transition, we do see a spike in a lot of the risk factors for cardiovascular disease, and then subsequently a rise in then the cardiovascular events for women.
That's so interesting. And is it just the typical changes that you'd expect with age, or is there something specific to estrogen, do we think?
I think that is the end-all question. And the data suggests, and what the researchers suggest and the experts out there say, is that there probably is both a component of age in some of it, but there's such a spike that happens around the time of menopause that it's more than just age. It is some hormonal relation.
That's so interesting. Okay, so one of the interesting findings that has been somewhat recent is that there may be a link between hot flashes and cardiovascular disease, cardiovascular events.
Sure.
What do we know about that?
So this is where we get into the weeds a little bit. So what we do see is that around the time of menopause, our estrogen levels start to decrease, and estrogen is a hormone that affects both our ovulation and pregnancy and all that good stuff. But it helps to affect our vasculature. So it keeps our vasculature pliable and resilient, as well as sort of helps control our blood pressure over time. And so as that estrogen level drops with menopause, we see that the blood vessels get stiffer, our blood pressure gets higher. We can start to have some autonomic dyssynchrony, so we get palpitations, our heart feels like it's racing more, we get a little bit more short of breath, we feel hot flashes because the blood is rushing to different places. And that's a part of, we think that association between that vasomotor reflexes of hot flashes is maybe associated and linked to some vascular dysfunction that we see with cardiovascular disease. So we think that link between hot flashes and the higher risk of cardiovascular disease in patients who are very symptomatic is maybe related to that vascular dysfunction that happens around the time of it. menopause.
It's such an interesting finding because anything that helps predict and prevent heart disease is important, but it's one of the many reasons why I always tell patients hot flashes are not something that we want you to suffer through.
No.
They're so disruptive to quality of life and they can affect other health parameters. And so this is one more thing to add to that list that these might be
associated
with something that's more sinister or important.
Yeah. I think from a cardiac perspective, when my patients don't always tell me about their menopause timeline because I'm not there for that, but it is an important part of that. You should tell your cardiologist, if you have a specific cardiologist, that you may be having more symptoms because your risk when we talk about risk factors for heart disease, it is one of those risk factors that we have to take into account for our patients. There's a number of other risk factors that we can go through about some of the things that we want to look for, but we can talk a little bit more about hot flashes.
So, while we're on the risk factor topic, what are some things that women can look out for as signs that they might want to prevent or talk about?
And I think that is looking at risk factors is the main thing that we want to be aware of. You want to be aware of that cardiovascular disease is present and higher in prevalence for certain patients and for certain women. And you want to be able to identify those patients who are at high risk, who maybe need to have a little bit more aggressive treatment or monitoring. So those patients who have a slightly higher risk are women who have high blood pressure, women who have diabetes.
Wait. So blood pressure.
Blood pressure, yeah.
What is, I often will see patients that their blood pressure seems higher than normal, but it might not reach criteria. So what would you consider high blood pressure?
Yeah, so elevated blood pressure is actually above 130/80. So that's technically an elevated blood pressure reading when you're in the 130s. You start to become hypertensive by diagnosis around the 140/90 range. And then above that, you start to get into the stages of accelerated hypertension. Depends on the patient, but we don't always treat for just elevated blood pressure. We usually treat for when you're in the 140s and use lifestyle beforehand, depending on, again, your risk factors and patient specific.
Okay, but it is, so 130/80 or above would be maybe a warning sign. This is something I need to pay attention to.
Because normal blood pressure is 120/70 and below. So actually less than that is actually normal.
Okay, so blood pressure is one risk factor. Elevated blood pressure is one risk factor. And then you mentioned
diabetes. So monitoring for diabetes or prediabetes, you're still at a slightly higher risk by having that insulin resistance of prediabetes and diabetes.
Okay.
And then cholesterol is another marker that we can look at. And so getting the full cholesterol panel, and we can go through that a little bit. But LDL, which is your bad cholesterol, it's the marker for cardiovascular disease. When that's elevated, we do see a higher risk of cardiovascular events down the road. And when it's lower, we see less events. So a very elevated LDL is around the 190 range. That needs to be treated. In between 100 to 180 is sort of an intermediate number.
Okay. So LDL, more than total cholesterol?
More than total cholesterol, it's more marked linearly, but total cholesterol does play a role too. So total cholesterol above 200 would be elevated, and way above that would be concerning for us.
Okay. Okay, so risk factors, high blood pressure, diabetes, and elevated cholesterol, specifically LDL.
Yep. And then since we're talking about menopause, so from a women's specific risk factors, if you have an earlier menopause, you actually do have a higher risk of developing cardiovascular events down the road. So menopause for most women happens around 50-ish. If you have menopause before age 45, your risk is higher. And if you're less than 40, your risk is actually very, very high. So every year, your risk goes up by about 3% from premature menopause.
That's interesting, but it is consistent with what we're starting to understand estrogen's role on the blood vessels is. So very, very interesting.
Very interesting.
What other details about a woman's reproductive history may have an association with health?
And this is something that's come about in the last 5 to 10 years that's really become more prominent and recognized, that women who have Hypertensive pregnancy disorders have a higher risk of developing cardiovascular disease and high blood pressure and thus cardiovascular disease in the future. So those more specifically would be preeclampsia, premature birth for the baby, small for gestational age babies. Actually, those women end up having a higher risk for cardiovascular disease down the road. HELLP syndrome, and then high blood pressure during pregnancy, before, during, and just immediately after can also lead to an increased risk of cardiovascular disease down the road. Recognizing that you have that risk factor and should be monitored a little bit more closely is, I think, the primary thing that we have learned over the years.
Okay. Yeah. All right. And then are there any other things that we could avoid that would convey a elevated risk? I'm thinking about like
yeah. As we were talking, I was like, oh, I didn't even mention smoking. Smoking is a huge risk. I feel like it's taken for granted because we all know smoking shouldn't. But we should say it. Yeah. Smoking is a high risk for cardiovascular disease development, and avoiding it and quitting is one of the best things you can do for your health.
Yeah, I do. Most of us know it, but I think hearing it and doing our best to avoid and quit would be helpful. So many of my patients that I see in the menopause midlife and wellness center come to me and say, oh, since I've went through menopause, I feel like I'm just gaining weight. It's hard to lose weight and it's uncomfortable. And from an aesthetic standpoint, no one likes it. Right. But is it relative to this conversation? Is there an association with increased body fat and heart health?
So in terms of menopause, we do see that that change in hormones does affect where our fat actually goes. So most of when we're young, our fat sort of deposits in our hips or the chest area or other places around the subcutaneous, our subcutaneous tissue. That's the tissue underneath the skin. As we go through menopause and the estrogen changes and our hormones change, the fat actually deposits more around our organs. So you end up having a higher adiposity or fat placement around your belly. So you end up having abdominal girth increase, which is a part of the metabolic syndrome that can develop, that women that during menopause are higher risk for developing that. I just blanked completely. Anyway, abdominal girth and the adiposity, sort of having your fat deposit in the central area, actually does increase your risk and is one of the independent risk factors for cardiovascular disease for where your fat develops. So it can go around your organs in the central region, and then it can actually deposit all around and over your heart. And that's a relatively new finding that we found, that adiposity or fat tissue that deposits around the heart, specifically sort of on the heart itself, where it sits on the chest. Yeah. That adiposity there, when we see it and identify it, you actually have an increased risk of cardiovascular disease down the road from that fat deposition that's changed.
Okay. So one more reason that we do want to prevent and treat increase.
Yeah.
And I'm gonna, before COVID, when we did these things, not virtually, but in person, it was meant to be interactive. So I'm excited that some guests at home are starting to submit some questions. And one listener asked, when talking about blood pressure, if resting heart rate is typically 79 beats per minute, but can go up above 100, is there a concern? So resting heart rate, is that worrisome?
So this is an interesting topic. So I usually separate my heart rates and my blood pressures a little bit. They're very related because everything is related. Your hip bone's connected to your knee bone, all that stuff. So it's very related. But your heart rate variability is a normal thing. So heart rate should be variable. Technically, a normal blood pressure for resting heart rate is in between 60 to 100 beats per minute. That's the textbook. But not everybody reads the textbook. So people can have resting heart rates in the low 100s and be relatively okay and asymptomatic, meaning not feeling it, not having any side effects from it. And people can be in the 50s as well, and that's okay. You want to have your heart rate be variable during the day when you're exerting yourself or stressed or in pain or anxious or talking or angry or emotional. Your heart rate goes up. That's a normal response to stressors. And it goes down when you're resting and asleep, so that can be very normal. I think if you're asking, is it normal for your heart rate when resting to go from 79 and jump up to 108? I would say sort of what other context is going on there. Are you watching your watch and you're seeing it go up and down and you're sort of sitting there watching it? Part of that is that you're watching it, and the more we watch it, the higher and anxious it gets. And there's a whole cycle there. But usually 79 to 108 can be normal for you, but it depends on your situation.
Okay.
I hope that helps.
Yeah, and it makes me, I'm glad you pointed out that there is a range of what would be considered normal resting heart rate. I usually think that the healthier heart are probably the lower resting heart rates, but is that not true?
I'll say yes and no. So I'll say that our marathon runners and our athletes who were in the Olympics a week ago or whenever that was, probably have a resting heart rate in the 50s to 60s. They are athletic. They have athletic hearts. Their heart rate rests low. They go very quickly to very fast heart rates, and then they come down very quickly. That's a very conditioned heart. That's a good heart, healthy heart. But as we get older and our electrical system becomes sicker or just gets older, it ages, the heart rate can actually slow down as well for other reasons. So yes and no.
Okay.
That's why there's a big range in variability, and it sort of depends on your specific situation. And if you're feeling it, then maybe we can be evaluated a little bit further. But if you're not feeling it, then it's probably okay. And what I mean by feeling it is very palpitations, heart racing, beating funny, lightheadedness, dizziness, shortness of breath would be maybe symptoms that should be looked into if you're feeling that at the same time that your heart rate's going.
Okay. And so just to kind of finalize, the listener at home who was asking a question, even if you're just sitting at home reading and you're relaxing and you notice that your heart rate is changing, without any symptoms like palpitations or dizziness, it wouldn't be necessarily a cause for concern. Certainly, you should always talk about these questions with your provider, but not necessarily something that automatically elicits a worry. And we have another question that just came in, and this patient started menopause around the age of 42, still having hot flashes, not as often, but mostly at night. Is there something specific that we should be doing? So that's a good, the question is
segue.
early onset menopause, and how do we keep how do we keep you healthy in general and from a cardiovascular standpoint? So why don't I just say that generally for the average patient who has early menopause in her 40s, I recommend hormone replacement therapy, and normally we don't call it replacement, but in this case, since you typically would have been making a certain amount of estrogen, we give you replacement doses to keep your bones healthy, your brain healthy. And there's some data now that it also keeps your cardiovascular system healthy.
The hormone replacement therapy for our women who have early menopause, continuing it through natural menopause age, there is a trend toward better cardiovascular outcomes in those women, especially if they're symptomatic with hot flashes. It can be helpful. It helps for both of those risk factors for that person, specifically the early menopause and the hot flashes. So we do see that it helps for those women. I would say from a cardiovascular perspective, hormone replacement is, I wouldn't necessarily do it for someone who's at natural age of menopause if they don't have sort of other symptoms, because we don't necessarily know if it's protective from the cardiovascular perspective all the way. We have a trend, we have an association, but it's not necessarily 100%. Some of the early data suggested maybe it wasn't, and that later, it's a little mixed out there.
Yeah, it is an interesting topic, and I think that if Dr. Topic, if you would agree with this, as a menopause specialist, if I have a patient who is average age of menopause, so 50 or higher, and is symptomatic with hot flashes, then there is a role for hormone therapy, and hopefully we will have more and more evidence that starting hormones early could be heart protective, but right now I think it's unfair to say that that's the case. We don't have enough data.
Right.
In in a young patient who is menopausal in her 40s, even without symptoms like hot flashes, there are other benefits to starting hormones like bone health and possibly heart health, is what we're starting to find.
Right, exactly. And obviously each patient is specific, so we're being general here, but you do have to take into account some of the cardiovascular risk factors when you're starting any hormonal therapy, whether it's early or normal age menopause. Right now the guidelines say that if you are a high risk for cardiovascular disease, just starting out for other reasons, because you have cardiovascular disease already or something else, we don't necessarily go straight toward hormonal replacement therapy for those women. So it can be, you gotta speak to your provider a little bit.
Yeah, it's tricky because any extra estrogen can increase the risk of clotting disorders. And so someone who may be already at risk for that, we wouldn't want to tip the scales and then increase the risk. So we've known for a while that the timing of when we start hormones is very important, and that hormones in general is not a one size fits all. And it sounds like heart health also may follow that trend.
Yeah, it seems sweet, unfortunately.
So what should a listener at home who wants to be proactive and stay on top of her health be doing? What are the typical?
So we want to look at sort of what we can do to prevent disease from progressing if we already have something, or prevent it from starting off to begin with. So recognizing when you have a risk factor that can be modified. So what are those risk factors that can be modified? Smoking, so quitting smoking.
You heard it again.
Quitting smoking. And then exercise and getting into a habit of being as mobile during your day as possible. So a sedentary lifestyle is associated with increased risk of cardiovascular disease by itself. So getting steps in, if you like to use your step counter, exercising for at least 150 minutes of intermediate exercise during the week, 150 minutes total. So you can split that up however you want to split that up, and you can go above it. Great, please do. That's like 30 minutes, 5 days a week is basically what that would average out to.
150 minutes.
150 minutes
every week
of intermediate exercise.
Okay.
Intermediate exercise means that you're not sprinting for 30 minutes, but you're pushing yourself to the point that you're feeling like you're working, your heart rate's getting up.
Okay.
So smoking, exercise, and then our heart healthy diet. And this is pretty much the diet that you've probably heard about. So we have two different forms that have been documented to be helpful in cardiovascular disease by the data. It's pretty good data out there. That's the Mediterranean diet, and the other one is the DASH diet, the DASH diet. Both of them are very much focused on vegetable plant heavy, that you're using vegetable oils, so olive oil in the Mediterranean diet, that you are mostly vegetables, plants, and fruits on your plate. And you're using, when you have carbohydrates, you want to have total whole grains. So you want to have whole grain, whole wheat, the whole grain brown rice, the whole grain pasta, the whole grain bread. You want that extra fiber. And then you want to have the fish is very healthy for the heart, actually. So tuna that's not in oil, salmon, mackerel, those types of fish have a lot of those omega-3s that are beneficial to the heart and cholesterol levels. And then poultry is better than red meat. You want to limit your red meat, which is beef and lamb, and those more fattier cuts, to not more than once a week. Probably best not more than every 2 weeks. But everybody has a different diet regimen. So when you're having lean meat, lots and lots of vegetables, whole grains, and that's where you want to sort of focus when you're talking about a healthy diet.
Okay. Are there any specific supplements?
Let me go through the rest of the things that we can do from modifiable perspective, and then I'll talk about supplements, because supplements a whole other topic in and of itself. So we have the stopping smoking, the exercise, 150 minutes a week of intermediate moderate exercise, heart healthy diet, lots of vegetables, whole grains, and lean meats and fish. If you like fish, if you don't like fish like me, you have other options. And then you want to get your blood pressure checked on a regular basis, every year at least, with your primary doctor. You want to get your cholesterol checked on the regular, which for most people who have normal numbers, about every 3 to 5 years. But if you start to have higher numbers that start to rise, especially as you hit menopause or start transitioning, you want to get that checked just a little bit sooner with your doctor, and you can talk about what that maintenance would look like. Look at your blood glucose fasting levels as well. Same amount with that fasting lipid panel. You want sort of every 3 to 5 years, and if it's rising or changing, you may want to check a little bit more soon. Okay. And then keeping a heart healthy weight, or not healthy weight, a healthy weight for your body. Okay. And that's part of that is the exercise, the diet, and the heart healthy weight. So those are the main, and the smoking, those are the main modifiable things that we can do for our heart health. Supplements. So if you're leading me to talk about fish oil or omega-3 fish oils.
No, not leading at all.
What I'll say right now is that the data is very controversial about using the over-the-counter omega-3s. Having a fish oil supplement won't necessarily hurt you. There are some forms out there that may increase your LDL. So if you are choosing to go on that, you may want to talk to your doctor about just checking your cholesterol periodically to see where it is and where you are, based on whatever formulation you end up choosing from over the counter. There are some prescription versions that have been tested and have been shown to maybe be beneficial in lowering our triglycerides levels, but they haven't always been associated with the benefit of reduced cardiovascular disease. We know that from the dietary supplement of eating the fish and the fish oil and having it in your meal rather than a pill form, we see the benefit in the meal form. We don't necessarily see the benefit in the pill. And that's unfortunately still up in the air and hazy and things that we're still in arguments about in many of the cardiovascular world, but it's a good question.
Yeah, and in general, any question about supplements is always tricky because the data is going to be based on a bunch of different supplements from different companies, and it's hard to make those, draw good conclusions.
Yeah.
Should everybody be on a baby aspirin?
Again, the aspirin has sort of gone the gamut of being everybody should be on it 100%, nobody should be on it ever, most people should be on it, and now it's sort of swung back on the pendulum, where 2 meta-analyses in the last 3 years came out looking at the benefit for primary prevention. Now, I got to emphasize that it's primary prevention that they're looking at. What that means is you haven't had a stroke, you haven't had a heart attack, you haven't had a vascular event in your peripheral vascular system, and you haven't been identified as having cardiovascular plaque buildup. So once you have had disease, you're in the secondary camp. So before you have an event, primary use of aspirin right now is not recommended for most women or most people, period, unless you have other risk factors that make you very high risk. That would be talking to your physician about that.
Okay, so I think, pause before just automatically starting it is what I hear you saying.
Aspirin can have a benefit for potentially, maybe there's a benefit for sort of catching early colon cancers and some of that, but we haven't seen necessarily a benefit in heart health that would outweigh the risk of bleeding that you get with just a baby aspirin. So that's where we're primary prevention. We're still a little hazy.
And what about statins?
So I love statins. I know that they have had some bad reputation out there, but they actually do really, really, really good work. And there's a lot of different formulations that people can try, especially if you get some of those aches and pains in the joints and the muscles. There's different formulations in the coenzyme Q10 that you can add that can actually decrease some of those secondary side effect symptoms that you get from the statin.
That's really interesting because many patients that have stopped it, they usually cite the
muscle aches and pain.
Muscle aches. So in some situations, CoQ10 might alleviate that.
Can be helpful. And then, like I said, you can do lower doses or different kinds of formulations that can be helpful. And depending on when do you start a statin depends on your risk profile. And there is a 10-year risk calculator that we can use. And then we can add some of those other risk factors like your family history, your pregnancy history, your own personal menopause history, if you're early menopause, that maybe will weigh into whether we start you on a statin earlier or wait until some of the numbers rise.
Very interesting. So what I hear you saying is there's not necessarily this magic bullet that we should all, or pill that we should all be taking to avoid heart disease, but that by not smoking, by trying to eat a healthy diet, exercise regularly, and get our cholesterol and blood pressure and fasting sugar checked,
Mhm.
we are being very proactive in preventing. Okay, so that said, if you have a family history of heart disease, is there anything beyond that we should be doing?
So this sort of comes into the other testing that we could potentially do. So we have other testing to look for risk factors. So if you're in that intermediate range already on that calculator and you're sort of on the fence about starting something, or your family history is leading your clinician to say, yeah, you kind of have a higher risk because you have early disease in your family. Early disease in family is women less than 65 and men less than 55 who have had a cardiac event in a primary first degree relative, father, sister, brother, grandparent, child. Those are the first degree relatives. Close enough. And so if you have that early risk and you have an intermediate risk factor, you may sort of talk to your clinician about what other options are there. There's coronary calcium score checking. And if you have a coronary calcium score that's elevated, your risk of cardiovascular disease does go up. So if you have that coronary calcium and that intermediate risk, I may recommend for that patient to be on a statin or other things, and maybe push a little bit harder for that exercise and diet change.
Okay. So it would be helpful to talk with your clinician
Always.
about any specific concerns you have related to family history. One of the issues that often comes up is if a woman is having a heart attack, how might her symptoms be different than the typical, my chest hurts, I'm having this event?
Yeah, so, and this I think is one of the biggest topics that we forget. The textbooks and most of the studies that were done for the initial studies were all done on men. And the women, a part of the studies were very minimal. It was less than like 10% for those beginning studies back in the 60s, 70s, before that. In the 80s and 90s and 2000s, we actually started to push to get women more involved in the study. So now we have data. That's why we have that pregnancy data that gestational hypertension leads to higher risk of cardiovascular disease, because we've pushed to have women as a part of a study, and it's important. So there you go. So what does it show? What does it show? So the classic textbook symptom, and if you have it, you should be worried. Heaviness over the chest, sort of a diffuse sort of heaviness right below your breastbone, just sort of aches, heaviness, like something's sitting on you, like an elephant sitting on you. It can radiate to your shoulders, either one. It can go up your jaw, and it can go to the back, higher back. And so if you have sort of a heaviness and then you have aches down the shoulder and upper arm and up the jaw, that you need to call an ambulance. That is very concerning.
Okay.
Women sometimes don't have that classic heaviness and arm numbness that we talk about.
Okay.
Women can sometimes have more of a burning type of a discomfort right in that upper belly. We call it epigastric discomfort.
Okay, which might be like, oh, I might have had too much.
It can feel like heartburn.
Burritos.
Women often have more jaw discomfort than sort of that heaviness in the chest.
Okay.
Women can also sometimes have more of the back and the shoulder discomfort.
Okay.
Sometimes shortness of breath goes along with it. You get sort of a clammy sweatiness sometimes when you're having a heart attack as well. So shortness of breath, sort of that clamminess, sweatiness, heaviness, jaw pain, back pain, or like a burning type of a sensation can sometimes be heart disease. It can be hard to tell because the esophagus and the heart and the lungs all sit right next to each other. So. Okay. But if you're concerned and something doesn't feel right, you should always get checked out. I never begrudge anybody getting checked.
Yeah, and I think it's such an important point that might be worth emphasizing, that if, especially women have good spidey sense. So if you feel like something is wrong, but it's not that classic, my chest hurts or, an elevator sitting on my chest, it could be more subtle signs that you're having a heart attack. So
women tend to have sort of less of that focal area where men have a focal stenosis in the artery that sort of blocks the flow, and that causes a massive heart attack, which is that heaviness. Women tend to have sort of a lot of diffuse disease rather than focal disease, so it can be sort of a different deposition of the cholesterol and plaque. But that gets into the weeds, but it's very interesting. So women have a slightly different presentation than men, a different profile and a different prognosis a little bit.
That is pretty interesting, and it's also it's neat, but it's sad that it's taking this long. That we're learning so much now about women's health and particularly heart health.
Yeah. And my forebears, my women forebears who've been in cardiology, Dr. Noreen Wagner, and all these wonderful women who've sort of pushed to get women into the studies and to learn more about it, I think is huge. So I applaud them.
Yeah. Yes. Okay.
Other questions, I think.
Let's see. So I am going to see if we have any other questions, and please continue to submit them. Okay. What more can be done to decrease abdominal girth associated with the menopause transition, aside from exercise and eating well?
Again, there's not that magic bullet, and I wish there was. It would be so much easier, right? But actually being aware that this is happening is part of it, and making strides to make those changes early rather than later is the best thing that you can do. We may not get rid of that abdominal girth 100%, but if you minimize it, that decreases your risk of that metabolic syndrome, which is the insulin resistance, the abdominal girth, and the triglycerides and blood pressure that start to, triglycerides and cholesterol levels that start to rise. So dietary changes, focusing on the whole grains can be helpful. Lots of vegetables, exercise, not smoking.
And I would add that it can feel frustrating because many of us have been on a million diets in our life, and we've yo-yoed, and some things have been mildly effective, but maybe not sustainable. But I do believe that the foundation of our health in general begins with eating well, being of a healthy weight, exercising, getting good sleep. And what I say all the time is small changes can have a big effect. So while you might feel frustrated that it took me 3 months to lose 5 pounds and it's slow going, but those small changes beget more positive changes.
So 100%.
It's still very worthwhile. And what I've come to find is that there's not always the perfect diet solution for every woman, but almost always there is something that can be effective.
Right.
And we have, a few months ago, we did a Meno chat with a weight loss expert.
Excellent.
We have a wonderful weight management program at WellSpan, and it's available in the virtual, available virtual. So there's resources out there, that being one of them. And so I would, in addition to exercise and trying to eat healthy, access some of the options that are out there.
Right. And what I'll emphasize is that, we talk about sort of abdominal girth having the higher risk because it's the fat around the organs. And you may not ever get rid of it 100% because everybody's body has a slightly different shape. It's more about finding that healthy weight for your body and sort of minimizing where that abdominal girth, which usually happens because of that sort of insulin resistance type picture, which gets better when you have sort of the whole grains, lots of vegetables, and exercise. It's that change in metabolism, unfortunately, that we can't really reverse, but we can fight against a little bit to make it a little bit better by finding a healthy weight for everybody.
Healthy weight for everybody. I like that. Okay, so our next question is, I started menopause in my early 30s and now I'm in my mid 50s. I am in excellent health. When should I begin seeing a cardiologist?
What I'll say is that for the most part, our primary care colleagues and our OB/GYN colleagues do a very good job of managing some of these prevention. And if there's ever a question that comes up and you want to ask them, you say, is it reasonable to see a cardiologist? Or even if you just want to see a cardiologist for primary prevention, it's not unreasonable. If there was ever a marker that sort of showed abnormalities in your routine blood work with your primary, where you're checking your blood pressure at least every year to every couple years, your cholesterol checked every 3 to 5 years, your fasting glucose checked every 3 to 5 years. And if you're finding sort of something is not right or rising or changing, that might be a time to just get a cardiologist involved. But I don't think you have to jump up and down and see one. It's just a matter of finding the person who's going to help you decrease your risk, which, like I said, a primary doctor does a very good job with that. Our family physicians and internists do good work. So you should be in good hands, but the cardiologist is, well, I'm here. And my colleagues are all here for primary prevention as well. We're happy to chat.
And additionally, if you ever became symptomatic, then of course that would elicit a whole other plan of care.
Right.
Okay, so I am going to, let's go to the next question. Is there a hormone replacement therapy that isn't chemical pharma prescribed, Premarin or other, and is it true that Premarin is pregnant mare urine? So the question about where we get our hormones from is a good one, and we do know that there's data that the source of the hormone can have an effect on our how healthy they are.
See, I'm learning something too. I didn't know that.
Yeah. So in the largest menopause study, the Women's Health Initiative, they used conjugated equine estrogen, and we know that a more molecularly similar estrogen to humans is likely has a more favorable effect on lipids. So anyway, this question about the source of hormones is a good one. And fortunately, we have really good options. Premarin is animal-based or sourced from animals. What we use more commonly, what I use in most of my patients, is a hormone that is either synthesized in the lab or based from plants, but is the same molecule, estradiol, which humans make on their own. So it's natural to us. And again, there's some that do come from the lab, but we also have options that are plant-based. So I wouldn't limit that from if you and your prescriber feel like hormones are right for you, there are options out there that are not animal-based. Okay, going on to the next question. Bear with us. I'm wondering. Okay, maybe let's go to this one. Thank you for addressing women's symptoms. I lost my mom to a cardiac event before this information came out, and she had all those symptoms.
I'm sorry to hear that. Yeah, I'm glad we do have the new information, and hopefully we can get the message out a little bit more, but I know it still goes under-recognized sometimes, so I'm sorry for that.
Yeah, I think, and all of you listening are promoters of this important information. So we'll get more and more get this information out so we can prevent this from happening unnecessarily. The next question is, if we are already menopausal on a statin and a blood pressure medicine, would it be beneficial to be evaluated by a cardiologist or to be proactive in slowing the process to a greater disease?
What I'll say to that is, like I said earlier, our primary colleagues, our family medicine and internists do very good work, and they will definitely start the process. If you have any concerns and want to be a little bit more aggressive, which is totally fine, sometimes the cardiologist is a little bit more comfortable with pushing numbers a little bit more than sort of some of our other colleagues. So it's reasonable to see a cardiologist for primary prevention, have a discussion, definitely. And then like we talked about, if you ever have symptoms, it's always a good idea to check.
Yeah. But it sounds like that the standard would be to do this evaluation of blood pressure and cholesterol, and possibly, depending on the patient, utilize medications that are out there. Right. But
I mean, if we're already on a cholesterol medication, what I'll say is that if we're already treating, so we already have high blood pressure and high cholesterol, so we're already sort of have target goals. And I think a cardiologist can sometimes be a little bit more aggressive because we sort of push those goals a little bit more in our for what is that primary prevention patient, that patient who has not had an event yet but has the numbers and the potential. We may push a little bit more to try to get the numbers just a little bit lower. But being on them is also very appropriate as long as you're hitting your goals and then having the lifestyle changes on top of that, which is that dietary change and the exercise. So you're already doing great work. You're already on the check. You're getting checked. You're on the right medication. It's just sometimes it can be helpful to push a little bit further, but it's also okay to sort of be where you are, depending on your personal risk factors. So having that discussion with your primary provider is reasonable. And if you want more, there's always okay to have a conversation for prevention.
Yeah, we're so lucky that we have such great specialists like yourself here. Okay, let's see. Any other questions? Ooh, is MCT oil harmful to heart health? So those are the why I'm blanking on the MCT, but it's a it's the in the keto world it's used a lot as mixed chain fatty acid.
So so that's a sort of very dietary specific question.
Yes.
And sorry, I wasn't familiar with MCTs. So mixed chain. Okay, so I'm not sure I'm the right person to answer that. Just because the data would suggest that the higher fat diets, the ones that have the monounsaturated, or you don't want the trans fat. That's a no-go. It's even illegal by the FDA to have it in any food, to have trans fat. And the monounsaturated fat is less healthy than the polyunsaturated fat. So you want sort of that mix of sort of the polyunsaturated fats with the oil, the canola oil and the olive oil, and some of those other plant-based oils are better. I don't know that much about MCT to say definitively whether it will affect your heart or not. And then the keto diet specifically, it's a very fat-heavy diet, and the data is mixed about how helpful that specific diet is for the heart or harmful for the heart. We don't have great data. What I'll say is that the keto diet, if it's followed religiously, following your ketones in your urine, and you are following it fairly closely, and you're not just having straight up bacon every day, it can be reasonable for both weight loss and subsequently okay for your cholesterol and your heart healthy markers. And it can be helpful for some of our diabetic patients as well. But I don't recommend it to everybody, because it can be a very strict and limiting diet, which can be non-maintainable. And you want something that's maintainable to really maintain your overall health. And if it works for you, great, and you think you can keep going with it, fine. Just being mindful of what are healthy fats and what are not healthy fats. So avocado oil, olive oil, some of those other sort of plant-based oils are better than some of the manufactured options that are out there. And you really don't want a lot of animal fat necessarily.
Yeah. And I think in general, things that are heavily processed aren't good.
As good. And the data sort of supports the heavily processed. Anything that's heavily processed, even if it's a healthy, heavily processed, is still not as good as just having raw food.
Yes.
Or cooked food, but
Yes.
Yeah.
But I'm sorry I'm blanking on the MCT stuff, but
I apologize. I don't know it a whole lot either, so I'm not the best person to ask about it. I have to look into it.
Yeah, but it is, I think in general, just trying to limit the fats that you have to the healthy fats are important. Okay. Medium chain triglycerides.
Thank you.
Coconut oil.
Yeah. So coconut oil has a little bit of mixed messages, because it is a little bit higher in fat. It can raise your triglycerides a little bit more, unfortunately, from the data. But like I said, the data is very mixed. So having more of the healthier fats is better. From my perspective, what we know from the data is olive oil, the Mediterranean oils, which is olive oil for the most part, and avocado type oil type stuff is a little bit better than coconut. But like I said, I have to look into it a little bit more. So I apologize, I can't answer that fully.
It's, if I had to do it over again, I think, as much as I love doing reproductive endocrinology, the diet,
crazy.
Like obesity medicine and diet is so,
there's a lot of new stuff that's out there, but it's still so limited in what we really know is helpful or not helpful, and it can be hard to get so many mixed messages.
Yeah, it's overwhelming for me being in medicine. So and I think you can imagine that studying something like the keto diet, people do that very differently. Some people will go to McDonald's every day and just eat the burger. And other people will have it be a lot healthier version of that. So you can imagine the studies are going to be possibly skewed or affected by that. Someone is asking that whether past webinars are recorded, And all of these, all of our webinars have been recorded and are available on the Midlife webpage. So you can access all of them at any time.
Dr. Ochalski, may I interrupt for just a moment? Sorry.
Yeah.
So yes, they are all recorded, but unfortunately not all of them have been uploaded to the webpage yet. We have one dear soul who maintains our entire website, and she is very overwhelmed. So if anyone wants to watch a particular chat, send me an email. You have my email because I'm the one who sends out the reminder, and I will forward it to you directly. I'm hoping that we'll get all of the chats up on the landing page soon. I just don't want you to have to wait for that if you'd like to see what's available.
Thank you, Sue.
Sure.
Another question about nuts. I think that nuts are one of the healthier things that we can do. They have a lot of nutrients in them. They have potassium, magnesium, all those things that help a growing plant to grow that we need in our bodies. So I think it's a very helpful source of nutrition. But you know, as they do make things grow, they're going to have a lot of sort of fats and other things in them. It's not bad. It's healthy fat. I think it's a good fat. And I have no problems with nuts in your diet as long as you're not allergic.
Good point.
Yeah. Same with seeds, those types of things. Actually, you know, flaxseed actually has has some omega-3 in it, actually. So it can be if it's a non-fish source. And then if you're looking for other sources of omega-3 from a dietary supplement perspective, rather than the fish oil that comes from fish, if you're vegan, it actually comes from algae. So the omega-3 is made by algae as it metabolizes, and then the fish then eat that, and they accumulate it in their fat cells. So the fatty fish has the higher omega-3 because it's accumulated after eating the algae-rich diet that they have. Whatever. Something that fish eat. But basically, you can get other sources of it from non-fish.
And it's less fishy.
There are formulations that don't have some of that fish smell, but you gotta find it. And like I said, the data is very out there, a little bit mixed about whether it's actually helpful from the supplement form, unfortunately.
See, nothing beats the primary source, right?
Usually.
Okay, so or palm oil.
Yes, coconut palm oil, yeah, same thing. So yeah, I wish I could answer that more fully, but I unfortunately don't know. That, you know, it is a little bit fattier of the oils that are out there, and whether it hurts or helps, okay. Look into that. I don't know. I think the biggest takeaway is that, you know, recognizing that women do have heart disease, and that it is one of the leading factors for death for women is a very important factor. And recognizing it early is ideal, and modifying what we can modify early is also ideal. And that's part of sort of the prevention, is identifying, testing, and evaluating, and doing what we can to modify what we can modify.
And then I will add that right now the data don't support starting hormones simply to prevent heart disease in the absence of symptoms. But if you do have symptoms, that there may be an added benefit to decreasing some of the risk factors.
Right.
And when Dr. Topic joins us next time, which we are definitely going to be inviting you back, there may be even more new exciting research to share.
Yeah, we'll see. I know that they're working on some of the fats that happen, what happens with menopause and fats, so cholesterol levels. So we'll see. But
yeah, it's really interesting. So many fascinating studies are happening now, focused on women and particular the menopause transition, how it affects our heart health. So stay tuned. We will keep you updated in future Meno chats. And that's all. I hope you all have a very good evening. And thank you so much, Dr.
Thank you for having me. I'm very happy to be here.